morning, and thank you for coming to our session this morning. My name is Shondelle Wilson-Fredrick. I serve as the Chief Engagement Officer of the National Heart, Lung, and Blood Institute at the National Institutes of Health. And I'm delighted to have this distinguished panel of 5 presenters who will be introducing themselves before they deliver each of their wonderful presentations. So we're going to start our session off this morning with some opening remarks from Dr. Natalia Chalmers.
Good morning, everyone. I'm so delighted to see you all here. I think you've just multiplied the oral health champions, because once you hear the stories that we'll share with you today, I hope you will take what you've learned to your communities, your organizations, and recognize that really we cannot achieve health equity or improve clinical outcomes if people are in pain or have infections. And so you will see a lot of these stories resonating through all of our presentations as an opportunity. Such a pleasure to serve our beneficiaries for the last 2.5 years. I'm a pediatric dentist and have the pleasure of serving as the Chief Dental Officer for 160 million people that our programs touch. And just want to highlight with you two things. Last year, for the first time, we launched the Oral Health Cross-Cutting Initiative. So we bring people across the organization to advance and align in oral health programming across all of our components, Medicaid, Medicare, and Marketplace. And very high-level highlights. In Medicaid, the oral health services are essential and mandatory. So children have access. But you'll see in some of the results and reports, still, many of them face a lot of challenges. And for adults, states can decide if oral health services are covered, and you see how that impacts access and utilization in a few of our presentations. And in Medicare, half of our population is in traditional fee-for-service, the other one in Medicare Advantage. So many of the Medicare Advantage plans offer dental services, but under traditional Medicare, we have a statutory prohibitions of delivering dental services. And I'm so excited that over the last 2 years, we have made incredible progress in allowing payment for dental services that are inextricably linked to covered medical services. So now, if you are in Medicare and need an organ transplant or vulvoplasty or valve replacement, if you have had a neck cancer, or if you're receiving chemotherapy for any treatment, you will receive the exam and necessary treatment. So really remarkable progress in the Medicare space for dental services. And I want to share in Marketplace, so Medicaid, Medicare, and Marketplace. In Marketplace, many of you are aware that there was a prohibition for states to allow non-pediatric routine services. And just this year, we removed that prohibition. So starting in 2027, the 21 million enrollees in the Marketplace will have, states will have an opportunity to add dental services for adults, which again will increase access to dental care and the vital role oral health plays in overall well-being. I know many of you have traveled from across the country to be here, so you're health equity champions, and I hope you become oral health champions. But don't leave Maryland without knowing the name of Diamante Driver. How many of you have heard his name? Yeah, a few. Beautiful 12-year-old Diamante Driver in 2007 died from a tooth infection that spread to his brain. And so that is only to say oral health really can have little consequences. And his death was not in vain because the policy changed almost overnight, increasing rates for reimbursement and participation of Medicaid providers, right? So we want to remember his legacy, but also do so much better for all of the beneficiaries we serve in our Medicaid program, in our Medicare program, and in the Marketplace. So without further ado, you're about to have an amazing treat and hear 5 outstanding presentations, and I will turn it over to Dr. Carla Shoff.
Thank you, Dr. Chalmers. Good morning, everyone. My name is Dr. Carla Shoff, and I am the Senior Advisor to the Chief Dental Officer at CMS. And today I'm going to talk about a collaborative study titled Geographic Variation in Substance Use Disorder Among Medicaid Beneficiaries and the Impact on the Utilization of Dental Services. Okay, so this is an interagency effort between the Centers for Medicare and Medicaid Services, the Substance Abuse and Mental Health Services Administration, the National Institute on Dental and Craniofacial Research, and the National Institute on Drug Abuse. And here's our whole team. Substance use and overdose contribute to significant health, social, and economic costs in American communities, with economic consequences estimated at more than $1 trillion per year. A bidirectional relationship exists between SUD and oral health. Sadly, prior uninformed opioid prescribing by dentists contributed to the opioid crisis, with dentists often prescribing the first exposure to opioids in the context of adolescent third molar extractions. Given the bidirectional relationship of SUD and dental disease, dental care is critical across the SUD use and recovery life cycle. Addressing dental needs may have significant impacts. Hansen and colleagues documented how integrating oral health care into SUD treatment in Utah was associated with improved outcomes. The study found that providing comprehensive dental care was associated with improved SUD treatment retention, as well as post-SUD treatment employment, housing, and substance abstinence. This study aims to examine the variations in the prevalence of SUD at the state level and describe the rates and patterns of dental service utilization among adult Medicaid beneficiaries by SUD diagnosis status. This study utilized the Centers for Medicare and Medicaid Services unredacted 2019 Transform Medicaid Statistical Information Systems Analytic Research Identifiable Files. This study includes Medicaid adult beneficiaries ages 21 to 64. All beneficiaries included in this study are non-dually eligible for Medicare. To be included in this study, beneficiaries must live in a state that is not excluded for data quality concerns according to the CMS DQ Atlas. Beneficiaries from 5 states were excluded from all analyses. Beneficiaries from 22 states with high concern or unusable race and ethnicity data were excluded from all analyses stratified by race and ethnicity, 3 of which were already excluded for claims data quality concerns. This resulted in 30.3 million beneficiaries included in the analyses that were not stratified by race and ethnicity, and a subset of 19.8 million beneficiaries when stratified by race and ethnicity. Beneficiaries with an ICD-10 diagnosis code for a use disorder of opioid, alcohol, cannabis, cocaine, sedative, hypnotic, stimulant, or other psychoactive substances are considered to have an SUD diagnosis. Dental services are defined and categorized by the American Dental Association Code on Dental Procedures and Nomenclature, which is known as CDT codes. Chi-square tests were used to test for significant differences in the rates across categories within each group and whether category-specific rates significantly differ across SUD diagnosis status. Clustered robust standard error models were used to predict the odds of receiving a dental service, and these models fully address the clustered nature of the data at the state level. This map shows the geographic variation in the rate of SUD diagnosis per 1,000 Medicaid beneficiaries aged 21 to 64. As shown in this map, the state-level rates of SUD varied from 90 to 333 beneficiaries per 1,000. The highest rates of SUD, as shown using the yellow horizontal stripes, are in states in the Midwest and the Rocky Mountain region and parts of the Southwest region. Next, we look at the dental visit rates per 1,000 Medicaid beneficiaries by age group. The blue bars with dots represent the overall rates, the orange bars with diagonal stripes represent beneficiaries with SUD, and the yellow checkered bars represent beneficiaries without SUD. Focusing on the first set of bars for all beneficiaries in the study, 174 beneficiaries per 1,000 had a dental visit. Among those beneficiaries with SUD, 290 beneficiaries per 1,000 had a dental visit, compared to beneficiaries without SUD, where only 145 beneficiaries per 1,000 had a dental visit. Moving to the other bar charts, we see significant differences in the rates by age group. Among beneficiaries with SUD, younger beneficiaries have the highest dental visit rates at 313 per 1,000. Older beneficiaries without SUD have the highest dental visit rates at 161 per 1,000. These maps show the geographic variation in the rate of receiving a dental visit per 1,000 Medicaid beneficiaries aged 21 to 64 by SUD diagnosis status. The map on the left shows the rate for those beneficiaries without SUD, and the map on the right shows the rate for those with SUD. As you can see, in most states, the rate of beneficiaries who received a dental visit is higher among those with SUD. Here we look at the rates by sex. Females are significantly more likely than males to have had a dental visit. Among beneficiaries with SUD, the rate of dental visits is 304 for females and 266 for males. Next, we look at the dental visit rates by race and ethnicity. Among all beneficiaries, as shown by the light blue bars, Asian Pacific Islander beneficiaries have the highest rates of dental visits at 188 per 1,000, followed by non-Hispanic Black beneficiaries at 172 and non-Hispanic white beneficiaries at 171. Among beneficiaries with SUD, shown by the orange bars, Asian Pacific Islander beneficiaries again have the highest rates at 343 per 1,000. They are followed by non-Hispanic Black beneficiaries at 304, American Indian Alaska Native beneficiaries at 287, and Hispanic beneficiaries at 284. Here we look at the dental visit rates by rural and urban residents. Dental visit rates are significantly higher among beneficiaries living in urban areas at 176 than rural areas at 161 per 1,000. Among beneficiaries with SUD, the dental visit rate is 293 among urban beneficiaries and 278 among rural beneficiaries. The next chart shows the dental visit rates by state Medicaid adult dental coverage status. It is probably not surprising that beneficiaries who live in states with more adult dental coverage have higher dental visit rates. Among beneficiaries with SUD, those living in states with extensive dental coverage have dental visit rates of 361, compared to those living with limited coverage at 304, emergency coverage at 138, and no coverage at 114 per 1,000. For the following two slides, we focus only on beneficiaries who had any dental service during the year and examine the rates for specific dental services. Of those beneficiaries with dental services, 925 per 1,000 received diagnostic services. Diagnostic services include services such as X-rays or oral evaluations. The diagnostic service rates for beneficiaries with SUD and those without are very similar. However, when we move on to the next type of dental services, oral surgery services, which include services such as tooth extractions, the rates for beneficiaries with SUD are significantly higher at 453 versus 174 for beneficiaries without SUD. For the next service, which is preventative services, which includes services such as teeth cleaning and application of fluoride, we see a shift, with the rates higher for beneficiaries without SUD at 594 versus 411 for beneficiaries with SUD. For restorative services, which include resin-based composites or fillings, the rates are also higher for those beneficiaries without SUD than those with SUD. However, the rate difference is more minor at 363 versus 327. Again, the focus is on beneficiaries who had a dental service during the year. Beneficiaries with SUD are significantly more higher to receive adjunctive general services with a rate of 185 versus 108 for beneficiaries without SUD. Adjunctive general services include office visits for evaluation, palliative treatment of dental pain, and general anesthesia. Beneficiaries with SUD are significantly more likely to receive endodontic services, with a rate of 58 versus 44 for beneficiaries without SUD. You will hear more about endodontic services utilization from Dr. Burns in the next presentation. Endodontic services include endodontic therapy and root canals. Rates of periodontic services are higher among beneficiaries without SUD at 110 than they are for beneficiaries with SUD at 92. Periodontic services include periodontal scaling and root planing. Beneficiaries with SUD have significantly higher rates of prosthodontic removable services at 80 versus 39 for beneficiaries without SUD. These services are for dentures. We estimated 9 separate clustered robust standard error models predicting the odds of receiving dental services. These models include SUD diagnosis, age, sex, race and ethnicity, rural-urban status, and state Medicaid adult benefit coverage status. For brevity, we only show the results for the effect of SUD diagnosis on receiving dental services for each of the 9 models. This is the effect after controlling for the other variables in the model and clustering by state. For the first model, which includes all beneficiaries, we find that beneficiaries with SUD are 2.6 times more likely to receive dental services than those without SUD. The remaining 8 models include those beneficiaries who received any dental service. For those models, we find that beneficiaries with SUD are 2.1 times more likely to receive adjunctive services than beneficiaries without SUD. There is no significant difference in receiving diagnostic services between beneficiaries with SUD and those without. Beneficiaries with SUD are 47% more likely to receive endodontic services than beneficiaries without SUD. Beneficiaries with SUD are 3.6 times more likely to receive oral surgery services than beneficiaries without SUD. Beneficiaries with SUD are 16% less likely to receive periodontic services and 43% less likely to receive preventive services compared to those beneficiaries without SUD. Beneficiaries with SUD are 82% more likely to receive prosthodontic removable services than those without SUD. Beneficiaries with SUD are 11% less likely to receive restorative services than beneficiaries without SUD. Our study, which analyzed over 30 million Medicaid beneficiaries, uncovered significant disparities in dental service utilization and that was influenced by SUD, demographics, and geographic location. Our findings reveal that age, sex, and race ethnicity significantly impact dental service utilization. Females and younger beneficiaries with SUD, particularly from Asian Pacific Islander and non-Hispanic Black ethnic backgrounds, showed higher dental service utilization. This trend suggests underlying socioeconomic or behavioral factors influencing healthcare access and need. Geographic factors and dental coverage also play a crucial role. Beneficiaries in rural areas or states with limited adult dental coverage often seek treatment for more severe dental issues. In contrast, those in urban areas or states with comprehensive dental coverage tend to utilize a broader range of dental services, emphasizing the importance of healthcare accessibility and preventive care. The results suggest that advanced dental disease, often associated with pain, lack of function, or tooth loss, is highly prevalent among Medicaid beneficiaries with SUD. The finding that preventive and routine dental care services were less common among Medicaid beneficiaries with SUD suggests that research is needed on implementing such preventive and routine dental care in addition to emergency treatment. The promotion of dental disease prevention and intervention provides a significant opportunity for those with SUD, as this could mitigate dental pain and advanced disease that can serve as a trigger for those with SUD. In conclusion, this study highlights the complex interplay between health conditions, demographic factors, and systemic healthcare disparities in shaping dental service utilization patterns. It underscores the importance of developing future research to inform healthcare policy and interventions that address these multifaceted challenges to enhance dental care access and outcomes for diverse populations. Thank you. And I will now turn it over to Dr. Burns.
Hello, good morning. My name is Lorel Burns, and I'm a diplomate of the American Board of Endodontics and the current Oral Health Policy Fellow at CMS. And today I will speak to you about the impact of the COVID-19 public health emergency state coverage policies, and sociodemographic factors on the utilization of endodontic treatment among Medicaid and CHIP beneficiaries. And I'd like to give a special thanks to Dr. Chalmers and Dr. Shoff for their collaboration on this project. So, a little bit of background. Oral health care is essential to maintaining overall health. However, the financial barriers to receiving dental care are higher than for any other type of healthcare service. Thus, dental insurance is fundamental to dental care access. Now, the EPSDT benefit enables Medicaid to cover dental services for all child enrollees, and the passage of the Affordable Care Act made pediatric oral health care services one of 10 essential health benefits. As of 2021, 38% of United States children had public payer dental insurance. Dental services for children must be provided if medically necessary and at minimum must include the relief of pain and infection, the restoration of teeth, and the maintenance of dental health. And the specific procedures covered are left up to the individual states. In contrast, for adults, there is no minimum requirement for dental services, and so the states have the flexibility to determine which dental benefits are provided to adult populations or adult Medicaid enrollees. And as in 2021, 16% of U.S. adults had dental insurance through Medicaid. So thank you, Dr. Chalmers, and Dr. Shoff for the tee-up, but a little bit more about what endodontic treatment is, since that's what this presentation is about. So endodontic treatment aims to relieve pain and infection, and ultimately it maintains natural teeth that would otherwise need to be extracted. And so endodontics is a dental specialty that treats the living tissues inside of the tooth, also known as the dental pulp. And the most common endodontic treatment is root canal therapy, which is depicted in this slide. So a root canal therapy aims to remove the inflamed or infected living tissue inside of the tooth, clean and then disinfect, and then fill and seal so that we can maintain the tooth and prevent bacterial recontamination. So if you remember, the relief of pain and infection, the fundamental purpose of endodontic procedures, is the first requirement of dental services for children, which must minimally be included. So the objectives of this study were to describe variations in endodontic procedure utilization among Medicaid beneficiaries at the state level, and then also evaluate the impact of the COVID-19 public health emergency on the utilization of endodontic services at a national level. So to describe our methods, for this study, we used CMS T-MSIS data from 2019 through 2021. And that data was used to identify children and adults enrolled in Medicaid. So 27 states were included in this study, and 23 were excluded from analysis due to missing data or data quality concerns. The data set was then limited to any child or adult that had a dental visit during the study period. And dental visits were identified by current dental terminology or CDT codes. And so once the data set was limited to those with a dental visit, the utilization of endodontic procedures, which is a specific subset of CDT codes, were evaluated. So for children ages 0 through 20, 18 endodontic procedure codes were evaluated, and 2 categorical variables were created. First, we had partial coverage for states that covered 1 through 10 endodontic procedures. And then we had extensive coverage as a category for states that covered more than 10 of the endodontic procedures evaluated. For adults aged 21 through 64, we looked at 16 endodontic procedure codes and created 3 categorical variables: no coverage, partial coverage, and extensive coverage. And then finally, clustered robust standard error models were used to predict the odds of beneficiaries receiving an endodontic service. So covariates in the model included age, sex, race, ethnicity, urban-rural residence designation, and state-level coverage of endodontic procedures as outlined by the categorical variables previously mentioned. So moving on to results. This map depicts geographic variation in pediatric endodontic coverage at the state level in 2021. So as a reminder, partial coverage in blue meant that 1 through 10 of the 18 evaluated endodontic procedures were covered for children up to age 20, while extensive coverage in red indicated that more than 10 endodontic procedures were covered. So most states have established payment policies and criteria for 10 or more of the 18 codes that we examined, while other states establish payment policy for fewer codes. Note that under the requirements of the EPSDT benefit, states must establish medically necessary criteria and cover medically necessary services for children, regardless of whether or not those services are generally covered in the state plan. So states have pathways to seek prior authorization under EPSDT for services that are not otherwise covered. And so some states covered as many as 17 of the 18 endodontic procedure codes identified, while on the opposite end, the lowest level of coverage was 4 of the 18 endodontic procedure codes evaluated. And these maps represent geographic variations in pediatric endodontic treatment rates during the COVID-19 public health emergency among Medicaid and CHIP beneficiaries with a dental visit. And here you can see minimal annual changes, but a general theme is that most states show a general trend of increased use of endodontic services over the study period. And these bar charts show endodontic treatment rates per 1,000 by age among children with a dental visit during the study period. And so children ages 0 through 6 had the highest rates of utilization nationally for the endodontic procedures. These bar charts show endodontic treatment rates by race ethnicity for children beneficiaries with a dental visit. You can see that the highest level of endodontic treatment were in children identifying as American Indian or Alaskan Native. These bar charts show endodontic treatment rates by sex for pediatric beneficiaries, and minimal differences can be observed between males and females. These charts depict essentially no difference in treatment rates by urban-rural residence designation for children. So finally, this clustered robust standard error model predicts the odds of pediatric beneficiaries with a dental visit receiving endodontic treatment. And the results show that non-Hispanic Black race ethnicity and age above 6 years old were associated with being significantly less likely to receive an endodontic treatment. Alternatively, American Indian or Alaskan Native race ethnicity and living in a state with extensive endodontic coverage are significantly associated with being more likely to receive an endodontic treatment for pediatric beneficiaries. So keep all of that in mind, and now we'll transition to the adult population. So this map here depicts state-level variation in endodontic coverage for adult Medicaid beneficiaries as of 2021. And the highest levels of coverage were in states with 14 of the 16 endodontic procedures covered. 15 states did not provide any endodontic coverage to adult beneficiaries. So again, for adults, annual changes in endodontic treatment rates were minimal during the study period. But in states where annual changes were observed, there was generally an increase in the use of endodontic procedures over the study period. Presented here are the variations of endodontic treatment rates for adults per 1,000 beneficiaries with a dental visit. And these bar charts show a similar trend to the geographic differences. Minimal changes can be observed between age groups over the study period, and the lowest rates of endodontic treatment can be observed in adults ages 50 through 64. For adults, different trends for race and ethnicity can be observed in comparison for children. However, for both age groups, adults and children, non-Hispanic Black beneficiaries have the lowest endodontic treatment rates. Again, no real differences by sex can be observed for adult beneficiaries, and this was consistent with what we saw among pediatric beneficiaries. Now, in contrast to what we saw in children, adults with rural residence designation had lower rates of endodontic treatment than adults residing in urban areas. And when we look at the covariates in the clustered robust standard error model, we can see that the most significant predictor of adults with a dental visit receiving an endodontic treatment is state-level coverage. Adults residing in states with extensive endodontic coverage were almost 10 times more likely to have an endodontic treatment than adults living in states with no endodontic treatment coverage. Urban-rural residence designation was the only other significant covariate. Rural beneficiaries are 23% less likely to receive an endodontic treatment than those residing in urban areas. So in conclusion, this study found that the COVID-19 public health emergency had a minimal impact on the utilization of endodontic services among Medicaid beneficiaries who had a dental visit. It is important to note that this study controlled for people that had access to a dental service. So this likely influenced the results regarding the impact of the COVID-19 public health emergency on the utilization of endodontic services at the national level. So next steps could be to investigate this phenomenon at a state level. For child beneficiaries, the utilization of endodontic services significantly varied by age, race, ethnicity, and state-level coverage of endodontic procedures. And lastly, for adult beneficiaries, the utilization of endodontic services significantly varied by place of residence and state-level coverage of endodontic procedures. Thank you.
Good morning, everyone. Yes. My name is Astha Singhal, and I am an associate professor at University of Florida and a diplomate of the American Board of Dental Public Health. And today I'm going to talk about the project where we looked at dental care utilization among Medicaid beneficiaries who were pregnant, and looking at state-level factors and individual factors that affect dental utilization. I want to start by acknowledging the wonderful collaboration with CMS and my team over there. We've had a great time working together. So pregnancy is a time of drastic physiological changes in a woman's body, and those physiologic changes predisposes them to specific oral conditions. So the hormonal changes that accompany pregnancy predisposes a woman for gum diseases, including gingivitis and periodontitis. Women who are pregnant may also be at a greater risk for developing cavities because of dietary patterns, and also dental erosion because of morning sickness. So these are some unique challenges associated with pregnancy. Moreover, the woman's oral health during pregnancy not only affects her own health, but also the health of the baby and the outcome of the pregnancy. So there is strong evidence that shows that gum disease during pregnancy is linked to low birth weight of the baby, preterm birth, and also spontaneous abortions. So there are significant implications for the mom, the baby, and their health in future. Despite these implications and evidence showing that dental care is both safe and effective during pregnancy, very few women actually use dental services during their pregnancy. And that's due to a whole bunch of reasons, such as misperceptions about the safety and effectiveness and the need for dental care during pregnancy. It is also due to lack of affordable access to dental care or lack of dental coverage during pregnancy, as well as the dental provider availability. Sometimes it's the dentists who are not comfortable treating a pregnant woman. So the objectives for our study were to examine patterns of dental care utilization among Medicaid beneficiaries who were pregnant. And we really focused on three main outcomes. We looked at any dental service used during pregnancy. And then we looked at oral evaluation, which is a proxy for more prevention-focused visit rather than a problem-focused visit. And then the last outcome we looked at was emergency department use for dental problems during pregnancy. And that is, again, a proxy for lack of access to a dental care provider that, pregnant women may end up in a hospital ED. So we looked at, again, individual level factors as well as state level factors and saw how it affects those three outcomes. The data that we use is the same data set that you've heard about, is the TMSIS data from 2021. And for our project, we included Medicaid beneficiaries between the ages of 15 and 44 years, as that captures a majority of the childbearing years. And we included about 1.18 million Medicaid beneficiaries who were in this data set for a single year. And then when we stratified by race ethnicity due to some missingness, we ended up with about 900,000 Medicaid beneficiaries. We used procedure codes that are outlined by the ADA to identify any dental service use, oral evaluation. And then we use codes by ASTDD, which is another state and territorial dental directors association, to identify the emergency department visits for dental problems. And then we use chi-square tests in our bivariate associations and multi-level logistic regressions to look at odds and how they differ across different subgroups of the population. So this map here shows variation in adult dental coverage specifically for pregnant women across the US. As you heard, dental benefits are covered for children in all 50 states, but for adults, it's optional, leading to this sort of variation. So here, the states that you see with the red pattern are the states that have a fairly extensive benefit coverage for pregnant women. And then the states with the blue stripes are the ones that cover some dental services, but not to the level of extensive coverage. The states in gray over there were excluded due to data quality issues as reported in the DQ Atlas by CMS. This is another plot which looks at our first outcome, which is any dental care utilization. And again, we see that there is quite a bit of variation in the rates of dental care utilization by pregnant beneficiaries. The states in the yellow stripes are the states that had greater utilization, followed by the ones with the red pattern, the blue stripes, and then the darker blue patterns are the states that had the lowest utilization of any dental services among pregnant Medicaid beneficiaries. This next plot is a similar plot, but here we are looking at oral evaluation. So again, that prevention-focused visits. And we see a somewhat similar pattern, but there's a lot of variation. And then finally, the third outcome, which was hospital ED visits for dental problems during pregnancy. And again, we see a varying pattern. So here, the higher rates are undesirable. It's an adverse outcome. We do not intend for people to show up at emergency departments with dental problems. So this overall shows the three outcomes by different age groups. And I want us to focus on the first one here, which is overall dental care utilization during pregnancy. And this rate is per 1,000 enrollees. And in the blue bar, we have our first outcome, which is women who utilize any dental services. The ones in red bar are whether they had an oral evaluation. And then the ones in yellow are the ED visits for dental problems. And that would be consistent in a bunch of plots coming up. So it would be great if you can keep that in your mind. So if we look at overall utilization, we see that about 13.7% of women accessed any dental services during pregnancy. So just think about that number. It's a really small number. So it's, almost like 1 in 10 pregnant women saw a dentist during their pregnancy. And this is much lower than what's reported in survey-based studies, which are self-report, and also much lower than privately insured population. When we look at oral evaluation, that's about 9%, and then about 1% pregnant women went to the ED for a dental problem. By age group, we see a clear difference between the youngest age group here, 15 to 20 years old, versus the two older age groups, 21 to 34 and 35 to 44 years old. And that's kind of built into how the benefit is provided, right? So again, 15 to 20-year-olds are considered children and eligible for EPSDT benefits. And again, dental benefits are covered. And so we see a much greater utilization in that group as compared to the older groups there. This is again looking at those three outcomes. The first plot is exactly the same, the overall, and then we break it down by different race ethnicities. And here we see some interesting unexpected trends. So we see that overall dental utilization was greatest among American Indian and Alaska Native population, and then followed by non-Hispanic whites, non-Hispanic blacks, and then Asian and Pacific Islanders. When we see the oral evaluation, there is much less variation. It's more similar across the groups. And then we see a lot more variation in ED visits as well, being higher in the same groups that had overall dental utilization. And then this one here, we are looking at subgroups by rural and urban residents. And we see that the utilization was slightly higher among rural pregnant beneficiaries than urban pregnant beneficiaries. But when we break it down by oral evaluation or ED visits, they were fairly similar. Here we have utilization by state coverage. So again, those states that provide extensive benefits for pregnant women versus not. And we see a clear trend here as well. Utilization was much higher, whether it's any dental services or oral evaluation or even ED visits among states with more extensive coverage compared to the states without the extensive coverage. These, in the end, are the adjusted multi-level logistic regression models and forest plots from those. And then the dark blue line over here denotes one. So any of the plots that touch that one or cross that are not significant. So we can see that when it comes to age, compared to the youngest age group, the two older age groups were significantly less likely to visit a dentist during their pregnancy, and that could be due to the type of benefits. When we look at race ethnicities, we found some interesting and unexpected results. We saw that non-Hispanic blacks were significantly more likely to have a dental visit during their pregnancy than their non-Hispanic white counterparts. Asians and American Indians were significantly less likely to have a visit. And then when we look at the benefits, we see a clear significant result that states that have extensive dental benefits, beneficiaries residing in those states are much more likely to visit a dentist during their pregnancy than those residing in states without extensive benefits. This is a similar plot, but here we are looking at our second outcome, which is oral evaluation. And we see sort of similar trends. The older age groups were less likely to have a dental visit. American Indian, Alaska Native, Asian Pacific Islanders, and multiracial groups were less likely to visit a dentist. But here we see that non-Hispanic blacks and Hispanics were significantly more likely to have an oral evaluation be performed during their pregnancy compared to non-Hispanic whites. So these are interesting findings that warrant further investigation. And then again, a strong effect of the type of dental benefits provided by the state. And then finally, ED use during pregnancy. Here we see that a reverse trend. So here we see that ages 21 to 34-year-olds are much more likely to go to a hospital emergency department with a dental problem during their pregnancy compared to the younger age group, again highlighting a lack of access to dental care for that age group. We see that American Indian, Alaska Natives, and non-Hispanic blacks were more likely to visit a ED for dental problem during their pregnancy compared to non-Hispanic whites. And rural residents who were pregnant also went to the ED at a much greater rate compared to the urban counterparts. The dental coverage here in the state did not have a significant effect because that's crossing 1.0. So in conclusion, we see that dental care utilization during pregnancy among Medicaid beneficiaries remains extremely low at 13%. And that really highlights a need for further investigation and also different types of barriers. Our study also shows that certain subgroups of Medicaid beneficiaries face greater barriers to accessing dental care. It's not homogeneous across that population. And the state's benefit design plays a big role in who gets to access dental care during their pregnancy, which has such important implications for the health of the mom and the baby. Thank you so much. Steffany Chamut.
Hello, everyone. Thank you so much for attending. My name is Steffany Chamut. I am an instructor in oral health policy and epidemiology at Harvard School of Dental Medicine and 2021-2022 CMS and Health and Aging Policy Fellow. Today, I will present the association between oral health disorders and Alzheimer's disease among Medicare beneficiaries living in nursing homes, and this is with the goal to advance health equity. But first, I want to acknowledge my appreciation to my mentors and collaborators, Dr. Shoff, Chalmers, and U, and express the appreciation for the support that I received for funding the project through the Boston University Research Center, Alzheimer's Research Center, which received funding from the National Institute on Aging, and the views are those from the authors and not from our institutions. Alzheimer's disease is a complex neurodegenerative condition that is marked by cognitive and behavioral changes. It affects more than 6 million people in the US and is increasingly linked to poor oral health. And currently, there is no known treatment to prevent or stop its progression. Research has constantly shown a strong link between tooth loss and early signs of Alzheimer's disease and related dementias. For example, studies using senescence accelerated mouse strain P8 have demonstrated that tooth loss can impair cognitive functions and activate neuroinflammation in the hippocampus, underscoring the connection to Alzheimer's progression. In studies involving late middle age, old and older adults, fewer teeth have been correlated to faster left hippocampal atrophy in cases of mild periodontitis, while having more teeth is corresponding to having faster atrophy in severe periodontitis. This highlights the critical role of preserving healthy teeth rather than just retaining them to prevent Alzheimer's. And another study in Korean adults found significant association between tooth loss and increased risk of developing Alzheimer's disease. And this is suggesting that managing tooth loss as a preventive measure is important to reduce the risk of Alzheimer's among the elderly. Our research objectives were to examine the variations of the prevalence of Alzheimer's in nursing homes and describe the association between oral health problems and Alzheimer's among Medicare beneficiaries living in nursing homes. This cross-sectional study was comprised by 2.4 million people, dual eligible and Medicare beneficiaries living in nursing homes in the US, who were assessed for dental problems and Alzheimer's diagnosis using the minimum data set 3.0 resident assessment instrument in 2020. And 6 dental problems were assessed: broken or loosely fitting full or partial dentures, non-natural teeth or tooth fragments, abnormal mouth tissues, cavity or broken natural teeth, inflamed or bleeding gums or loose teeth, mouth or facial pain, discomfort or difficulty chewing, and Alzheimer's diagnosis. Chi-squares test and multi-level regression models were performed. For the following slides, I will only focus on the people and the beneficiaries that had Alzheimer's diagnosis, which is represented by the red bars. And as you can see in the first red bar, nearly over a third of our population had a diagnosis of Alzheimer's. And as the age of the Medicare beneficiaries increases, so is the risk of having an Alzheimer's diagnosis, with nearly half of the population age 85 and older having been diagnosed with Alzheimer's. So this is very high. And also, when we look at sex, the prevalence was higher among females, with 389 cases per 1,000 compared to males. And among all races, Asian Pacific Islanders have the highest rates of Alzheimer's diagnosis at 408 per 1,000 compared to followed by Hispanics. Notably, dual beneficiaries had the highest rates of Alzheimer's diagnosis at 439 per 1,000 compared to Medicare-only beneficiaries. And those enrolled for fee-for-service program have a higher rate of Alzheimer's diagnosis at 376 per 1,000 compared to those with Medicare Advantage program. Surprisingly, those with no chronic conditions have the highest rate of Alzheimer's diagnosis at 407 per 1,000 beneficiaries, while individuals with 3 or more chronic conditions have a lower rate at 291. The data also reveal a clear correlation between the number of mental disorders and the Alzheimer's diagnosis between beneficiaries. So beneficiaries with no mental disorders have a lower rate, and those with one mental disorder have a rate of 397 per 1,000, and the rate increased to 470 per 1,000 with those for having 2 or more mental disorders. Moving on, the study also revealed a discernible disparity in Alzheimer's diagnosis based on location. So with rural nursing homes having a higher rate of Alzheimer's diagnosis at 404 per 1,000 Medicare beneficiaries compared to urban nursing homes. And for the following 2 slides, I will only focus on the prevalence of dental conditions. For example, 410 per 1,000 beneficiaries were affected by cavity or broken natural teeth, and the rate for not having natural teeth or having tooth fragments was 408. In this graph, we're looking at the highest rate of dental problem that we had among all the assessments. So it's the second bar, and this is for the inflamed or bleeding gums or loose teeth, which is at 427 per 1,000 beneficiaries. But notably, any dental problem was associated with Alzheimer's diagnosis at a rate of 406 per 1,000 beneficiaries. This slide looks a little busy, but this is a forest plot, and I will help you to interpret in order to understand all the information. So the effects factors of the Alzheimer's diagnosis, I want you to focus on the dark line that goes into 1. And everything in the 1 shows no effect. And all the points to the left suggest less effect or less risk, and everything on the right shows a higher risk. And everything in parentheses are the areas that we were comparing to. For example, as we can see here, all the ages are to the left. And that means that when you compare them to the older individuals, 85 and older, the age is a factor. The older that you get, the higher the risk of developing or being diagnosed with Alzheimer's. And other key findings from the multi-level logistic regression model predicting the odds of Alzheimer's diagnosis include certain ethnicities, as you can see on the right, Asian Pacific Islanders, no Hispanic Blacks, Hispanic, multiracial, being dual eligible for Medicare and Medicaid, enrollment in a fee-for-service program, the presence of mental disorders, living in rural nursing homes, and having any dental problem significantly increases the risk or likelihood of an Alzheimer's diagnosis. In this chart, the category of non-natural teeth aligns with the dark line, indicating no significant effect. But on the other hand, to the right, we can see that beneficiaries with inflamed or bleeding gums or loose teeth are 22% more likely to be diagnosed with Alzheimer's. And those with cavities or broken natural teeth face an 18% risk of compared to those without the dental problems. Interestingly, experiencing pain, discomfort, or difficulty chewing is associated with a slightly lower risk of being diagnosed with Alzheimer's, but this finding aligns with other previous research, and it might be reflecting on underreporting because of the dental issues among Alzheimer's patients who face communication challenges, medication effects, or altered perception of the pain levels. In conclusion, there are clear disparities in Alzheimer's disease diagnosis among Medicare and dual eligible beneficiaries in nursing homes, influencing the factors such dental problems, demographic variables, dual eligibility status, and geographic location. Specific dental problems such cavities, broken teeth, inflamed gums, or loose teeth are linked to higher odds of developing or being diagnosed Alzheimer's diagnosis. And given the substantial oral health needs in nursing home residents, it is crucial, remember, crucial, for caregivers to receive proper training and guidance. So it is important to ensure that they're well-trained and knowledgeable to assess the oral health of these patients, especially for those facing challenges and those diagnosed with Alzheimer's disease, and they cannot communicate properly. Thank you so much.
So I recognize that we are knocking on lunch's door, but we wanted to give all of you an opportunity to ask this distinguished panel of dentists, scientists, and researchers questions. I'll first like to see if there's any questions online. No questions online, so we're happy to pass the mic around to you all in the room to ask your questions of the panel. And we ask that you use the mic for those of you in the room so the folks who are online can hear your question.
So my question is in the relationship between Alzheimer's and dental health. Could the poor dental health be a result of the Alzheimer's and to access that dental care because of the disease itself versus having dental disease and then followed by Alzheimer's? Does that make sense?
Can you repeat the question again? Okay.
Which came first, the dental disease or the Alzheimer's? Yeah. Basically is what I'm wondering, if the dental disease is a consequence of them having Alzheimer's and fear of dental procedures and dental care and things like that.
So given
Oh, do we need a mic here, or do we? We'll just use our outside voice so they can. You guys could just talk. Oh, just to talk. Okay.
In my belief and the research, it can be both. Dental disease or oral health problems are low progression, and it can start very soon, and you don't have the effects of the cognitive decline. But when chronic inflammation happens, is when it starts affecting the brain in many areas. Some other research has shown that it's like exercise. When you're moving, you're increasing the rate of your heart. The same happens when you're chewing properly. So you stimulate the two sides of the brain, and that is a healthy function. When you cannot eat on one side because you have an oral health problem, you compromise and you eat on the other side. So only one side gets stimulated. Also, the brain temperature of the brain changes. So all those effects increases the risk of Alzheimer's. On a patient with Alzheimer's diagnosis, the fact that they're not complaining or expressing the pain, the oral health problem advances and people realize until too late. So it can be both.
Yeah.
Did I answer the question?
Yes,
you did. Thank you. That's very helpful.
And if I could add one piece, I think the common denominator there is low-grade inflammation. So when we think about oral diseases, periodontal disease is often what people say, but really the common mechanism there is that inflammation that's constant. Alzheimer's doesn't happen overnight.
Right.
And knowing the barriers to access to preventive oral health care for many seniors only leads to that, slow progression of the oral health problems and the potential impact. But the science actually is really exciting. And we now know that oral bacteria can be found in some of the plaques within the brain. So there is a direct biological connection between that low-grade inflammation and the infection. It's periodontal disease infection process that drives inflammation. And the more we know, the better we would understand that connection. Definitely lack of teeth is associated with higher incidence of Alzheimer's. But the way you get to know teeth is because they had infection and then they had to be removed, right? So all of this takes time. And it really was never on the horizon that, hey, keeping your teeth has a really huge impact. Another way to think about it is, what happens when you lose all your teeth? Just you probably stop communicating. So oral health is not just about, teeth and smiles, but communication. And the moment people stop communicating, that impacts social interactions and cognitive development and progression of some of these symptoms. So it really is bidirectional. But now there is this biological component where it's like, oh, the bacteria actually can make it through the brain barrier. Fascinating. Yes. This is why the news articles were highlighted in the beginning, because it's a new area where we're learning so much more that how this happens. And as Steffany said, it's really a process, and all of these happen at the same time. And at the end, you have sort of the combination, right? You have no teeth, and then you have potentially a diagnosis. Yes.
And thank you very much for presenting all this information today, Dave Merrill, GDIT. Quick question for you. And just to kind of dovetail on what you're saying there's obviously a correlation at the, when somebody has Alzheimer's, and if they're dual eligible and they're on Medicaid as well, that there's a prevalence. And then there's an interesting tie back to what you're just saying with the fact that if you look at the rates of preventative care in Medicaid, like they're very low, right? I mean, you were mentioning the 13% there in one of those other slides. I thought I saw 5% on some of the other. So the question I think I have, did any of the studies really get to an understanding of why amongst those populations the use of preventative services were so low, and what steps potentially we could be looking at as a community to try to increase utilization of preventative services?
Yes, want to take a step at it, and then we'll talk about the offering.
Yeah, I think one of the the factors that I think appeared on a lot of our separate studies was dental benefit, what is covered in the state. So that's one of the big determinant of what services does this population have access to, and especially for adults where it varies from state to state, what a state chooses to cover in terms of dental services is sort of the bottleneck in access to dental care.
Yeah, if I could just add, coverage is the number one barrier. The second barrier is cost of care. So even when you have access, with the out-of-pocket spending can be a barrier. And then over the last year, our Office of Burden Reduction conducted a human-centered design where we interviewed beneficiaries, providers, and state-level advocates to say, what are the barriers, right? And so the barriers are very different if you're at the state level or an advocate organization versus if you're a patient trying to find a dentist versus if you're a provider. And just to highlight a couple of those, patients are saying they're waiting for 6 months to get an appointment. This is, to get a preventive appointment. So you can imagine dental disease. I mean, if you take anything from here, doesn't stop. It progresses, right? And unless you're able to find that access to care, things will only get worse and you'll end up in the emergency department, as you saw, right? Patients also said, I am working, 3 jobs, getting hourly wages. I can't take 3 hours to go to the dentist. 1 hour a day, 1 hour at the dentist and back. And then we know that there are additional challenges that are not specific to dental. Transportation, you heard it even this morning. It's like you can't get to an appointment. Provider participation, right? So yes, you have the coverage, but as you heard yesterday from our administrator, that is the first step. What is the next that actually gets you to be seen in a clinic where you have providers participating in the Medicaid program? And that's nationally very, very low. 40% of dentists only participate within the Medicaid program. So that's additional barriers. There are many others, and I would encourage you to look at that visual summary where the barriers were classified, what government can do in terms of coverage and the benefits, and what are the providers saying, and provider burnout. I mean, we have to just acknowledge it across the healthcare system. They can't hire staff and supporting personnel. So that's another challenge of how many patients you can actually see, even if you have an office that sees Medicaid enrolled adults and children. And then again, we heard also from patients, they have to find childcare in order for them to go and, get that preventive visit. And often, again, they would prioritize the visit for the child, perhaps, and not for the parent. And they have that, mom and dad are making sure the kids get the preventive care. That's why you saw this great data of how kids are accessing, and then challenges for adults. It's really complex, not unsolvable. And I think that's one of the conversations we had early. One is intentional to understand the disparities and think about solutions. You really can come up with state level interventions that help.
So we have time for one more question.
More.
I mean, if you guys want to hang around, we can keep going, but I want to be respectful of your time.
Yes.
Too.
Maybe 2 more.
Yeah. Okay. Yeah. All right. Questions.
Yes.
Per Dr. Chalmers' request.
And of course, we're here to talk with you. Please. No? Okay. But you're raising it. Okay.
So I'm gonna.
Mike, to call the audience.
I'm just gonna comment and then ask my question. So, Charles Gabriel from the Federal Electronic Health Record Modernization. So I'm not a dentist or not even a medical doctor. So the stuff usually is kind of like pulling teeth for me. But you made it very relevant, very relevant. So I worked on interoperability standards for a long time. And I have witnessed the cycle of electronic health records since the legacy of military health and stuff like this. And I think we are on the verge of doing the same with dental. So first of all, I just want to thank you so much for being on board with CMS. And I appreciate CMS bringing the first chief dentist officer for the nation. The panel is amazing. But the more important thing that I did, even though I'm not expert in this area, is I asked the subject matter expert when we were doing dental exchange, is to switch the name to oral health exchange instead. And I think you made the connection very, very well. The one question I want is how can we promote this good work? I think there are some education to be on the medical side and dental side need to be happening, and it's not happening. And those researches are amazing. And then the information side of the team, because it's tend to be kind of in the blind spot of practitioners.
Well, thank you for the work you do in interoperability. And we didn't address this issue explicitly, but it is so relevant because if you're treating someone with substance use disorder, or if you need to send a referral to a specialist like an endodontist, or if you have an OBGYN patient who needs to be seen by a dentist, or someone with Alzheimer's, how do you do that? Okay. If you're in a medical system and you go to the emergency department for any GI issues, it's a click of a button. You go, yeah, referral, GI person, go. What happens for dentists? Oh, here is an opioid. By the way, number one reason of why adults walk out of the emergency department with opioids, dental pain. Place that with kidney stones. Okay, so it's part of the opioid epidemic and the product communication picture crisis. But back to this, what happens for dentists? Here's a prescription for opioids and antibiotic. Go find a dentist. There's no click button solution, right? Referring to an endodontist, even dentist to dentist. It's again, you write it on a script and send it in. You hope they find that specialist. So we have a lot of work to do in this space where from Alzheimer's to OBGYN to the dental specialist to the SUD treatments, first the awareness of the connection, but then really how do you make it work? Okay, I have this patient. If I'm not in an FQHC that offers dental and you can just do the walk, the warm walk through, right? That's one thing. But if it's referring to another provider, it's impossible sometimes to find connections.
And part of that could be modernizing and integrating EHRs and dental records, which rarely exist outside of FQHCs. So that's part of it.
I feel like the same way I said low grade inflammation is the common language. Having that shared understanding and interoperability is the shared connection between a dental and a medical provider. And we need to develop that language.
And I guess one thing. So it is also very important to add to your comment the importance of medication. Medications sometimes increase the risk of dry mouth, and those medications are being prescribed by the physicians, and there is no connection with the dental area. So if we get to know that, it will help to reduce the risk of tooth decay, for example.
Yeah. One last quick question. Is it any possibility that we will have a policy to make sure the safety for medication be required on the dental side of the team?
Mm-hmm. Well, I full transparency. I was a dental officer in the Food and Drug Administration, and I before that never read an FDA label on the side effects. But now I was like, oh my God, why is that everybody reading them? They're so full of great information, side effects, and to the point that was just made, the majority of the medications that are prescribed for anxiety, depression, one of the top side effects is xerostomia. I think it's, again, this lack of understanding and knowing. Dentists today rely on what the patient reports. Mm-hmm. I feel like these are the medications dentists should know. They don't report all of them, but if you were in their medical record, you would know. Oh, well, I know this puts you at a risk. Therefore, I'm going to do that. Mm-hmm. And that's just, again, the systems are not necessarily connected, but a huge opportunity. Same is, for OBGYN. A mom comes, severe morning sickness. I mean, immediately would be great for them to have, a visit to sort of put all the preventive things we can do so they reduce the impact of that morning sickness. Yeah. There's a lot of opportunities.
Perhaps pharmacists should be by the table too.
Absolutely, because they can also say, hey, you're taking, and the more we age, the more medications we take. And so it's not that it's additive, it's the cumulative effect of this drug has xerostomia, this one and this one. It's like, oh, maybe you need an alert for xerostomia because you're taking 4 of these, and together, basically, you have no saliva, which would mean rampant disease. And related to substance use disorder,
in 2022, the Food and Drug Administration released an advisory related to the oral health effects of buprenorphine. And so we know buprenorphine works. That is the number one priority substance use disorder. But it has very acidic pH. It's like having Sour Patch gummies in your mouth all day long. Well, it's not going to be good for your teeth. So it's really thinking through that priority of substance use disorder treatment, and then thinking through, okay, they need to see a dentist. They need to see the prevention in order to make sure that the impact is lessened. So huge opportunity for integration and addressing the health equity. Thank you, everyone. And thank you for coming. Yes.